I'm now excited to introduce our next guest speaker. For those of you who've been following our work for quite some time, you know that we're deeply interested in the policy and payment levers around maternal mental health and mental health more broadly. Amber Rivers is the director of the Office of Health Plan Standards and Compliance Assistance at the Employee Benefit Security Administration at the U.S. Department of Labor. Ms. Rivers serves as the Department of Labor's principal advisor on healthcare. She's responsible for review, analysis, and drafting of regulations related to employee healthcare benefits. She coordinates the agency's technical assistance to members of Congress and congressional committees regarding drafting of critical healthcare legislation. She also serves as the agency's liaison on health coverage related matters to the National Association of Insurance Commissioners who have oversight of health insurers at the state level and also to other state agencies. She's with us today to address the Department of Labor, or the DOL's, efforts to oversee the ongoing implementation of the Federal Mental Health Parity and Addiction Equity Act, referred to as Mental Health Parity. We are so extremely grateful for you joining us today, Amber. I'm going to turn it over to you.
Thanks so much, Joy. And I'm very excited to be with you all today. And as Joy mentioned, my agency administers the Mental Health Parity Act. It actually amended a broader law known as the Employee Retirement Income Security Act that contains requirements for retirement, health, and other welfare plans. And so it amended that law, and my office is responsible for issuing interpretive guidance under MAPIA. That's going to include regulations, things we refer to as sub-regulatory guidance, such as frequently asked questions, some technical bulletins. And in addition to that, we provide a lot of technical assistance and support related to that regulatory and sub-regulatory guidance. So we work very closely with our Office of Enforcement in ensuring that the interpretations that are advanced in investigations are consistent with the laws that we've put out. We work with other departments, which I'll touch on in a moment, as well in their efforts. We work very closely with state regulators as they are also enforcing the Federal Mental Parity Act requirements in their states. And then we also do provide technical assistance to members of Congress and committees as well as they contemplate legislation that may impact these particular benefits. And so I just want to talk a little bit about the jurisdiction that covers MAPIA and the various agencies that are involved. And while I'll talk about how the pie is cut up with respect to the health insurance market, I think the biggest thing to keep in mind is that we really use a no wrong door approach here. To the extent someone has a question or an individual is having some challenges with their benefits, we work very closely with one another to ensure that regardless of what door they come into, they're going to be routed to the appropriate place and they get the assistance that they need. But I do think it's helpful to just understand the regulatory framework and who's responsible for what before I talk about some of MAPIA's protections. So as I mentioned, the Department of Labor definitely is central here, playing a critical role, but we also work with the Departments of Health and Human Services, as well as the Department of Treasury. I will also flag that states have a very big role in enforcing mental health parity, and then also participants and beneficiaries. I'll talk about that in a moment. So the Department of Labor, our jurisdiction runs to employment-based group health plans. And so to the extent an individual gets health insurance coverage through their employer, let's say they're working at Pizza Hut or Verizon, and they're making an offer of health coverage, my agency would regulate those benefits. And it doesn't matter if it's a self-insured plan, meaning Verizon or Pizza Hut is paying the benefits out of their general assets, or if they go to Blue Cross to purchase a policy for their coverage. Either of those scenarios, my agency would regulate that group health plan. And HHS's jurisdiction in the states, they share jurisdiction. And so with respect to health insurance issuers, these are going to be your Blue Crosses, your Aetnas, the states have primary enforcement responsibility with respect to health insurance companies. Now, to the extent a state is not substantially enforcing, the Department of Health and Human Services will step in, they will make a finding of that, and then they will actually enforce these requirements with respect to that state. And so you'll see there's some coordination there. The Treasury, as I mentioned earlier, they share interpretive jurisdiction They typically are a little bit less active in the enforcement space, as our jurisdiction, us being the Department of Labor, we have extensive co-current jurisdiction with the Department of Treasury. So just so the market is covered between those three agencies as well as the states. And then the last thing I will flag is that under ERISA, participants and beneficiaries actually have a private right of action to enforce the requirements against their plan and issuer. So that is something that I did want to highlight to make sure that folks understood. So just turning now to the actual requirements of MAPIA, we've seen a lot of legislation related to this over the years. This, the first biggest piece of legislation with respect to parity was in 1996 with the Mental Health Parity Act, really looking to require comparability and annual and lifetime dollar limits. And then you fast forward to 2008, and I think this is a law that most folks are most familiar with, is the Mental Health Parity and Addiction Equity Act of 2008. And it really expanded those earlier protections. And I'll walk through the various protections here to try to really make sure that there's some comparability in benefits and the restrictions that are applied to benefits under the plan. And then we also had the 21st Century Cures Act, as well as most recently the Consolidated Appropriations Act of 2021, that further amended MAPIA to add some additional tools and protections. And so before I get into the actual requirements of mental health parity, just some baseline things to keep in mind. Unlike some state laws, federal mental health parity isn't a benefit mandate. It only applies to group health plans that are offering both medical surgical benefits as well as mental health or substance use disorder benefits under the plan. But the good thing is, to the extent an individual can elect different benefit packages together, they need to be offered in parity. So that's really designed to make sure that plans and issuers are not trying to circumvent the requirements of parity. And then just to talk a little bit about some of the protections here, one of the biggest things that 2008 law did was apply protections to what we call financial requirements. These are going to be things like copays, coinsurance, to essentially ensure that whatever a plan or issuer is applying in terms of financial requirements or copays or coinsurances to medical surgical benefits needs to be generally what's applied to mental health benefits in that same classification. And so I think that's a very important protection to highlight. And this is done with respect to different classification of benefits. So again, you're going to look to what are the copays that are applied for inpatient in-network versus inpatient out-of-network. The same for outpatient. You're going to look to see what are the copays, coinsurances there. There's also emergency care and prescription drugs. Another key protection to also keep in mind is that, if a plan provides benefits for a medical surgical condition in any of those classifications, they also need to provide mental health or substance use disorder benefits in all of the classifications to which they're providing medical surgical benefits there. So then turning away from the financial requirements, there are some requirements that apply to what we call non-quantitative treatment limitations, which are essentially what you think of as your medical management techniques. So that's going to be prior authorization, some of the utilization review, concurrent review. Those sorts of provisions also are subject to mental health parity. And there, what we're looking for is making sure that the processes, the strategies, the evidentiary standards that are used to develop and apply those limitations are comparable with respect to both medical, surgical, as well as mental health benefits. And there, you're really looking to see, why is the plan imposing prior authorization or concurrent review? What did they consult? Did they do it in a comparable manner? And that's what parity requires with respect to non-quantitative treatment limitations. There's also a requirement that applies to what we call cumulative financial requirements and cumulative quantitative treatment limitation. And these are going to be things like your annual visit limits, day limits. These are not permitted to accrue separately. Also deductibles, I think that's another important one to highlight. You shouldn't be seeing any separate deductibles or annual or day limits. Any of those limits that accrue over time, those need to make sure that they're aggregated together. And so those are just some of the general requirements that are provided under the Mental Health Parity Act. In addition, there are some disclosure requirements, which is also very important because this law has a comparability requirement. You really need to have information about both sets of benefits to ensure that the plan or issuer is offering benefits in parity. And so There are express disclosure requirements under MAPIA that plans and insurers must provide the criteria for medical necessity determinations, the reasons for any denial. And then we've issued a lot of guidance since then to really clarify the breadth of disclosure that's available, because what we find is when individuals are undergoing a dispute on a particular benefit, it's very important to have that information to be able to respond to whatever the claim decision may be. And so we felt the need to make sure to clarify that over time. And so that was the Mental Health Parity Act of 2008. And in between that time and the Consolidated Appropriations Act, I think we've generally seen increasing compliance with respect to some of the financial requirement rules. That's the rules I discussed that apply to co-payments, co-insurance, things of that nature. And I think generally because those are going to be easier to spot, there's a clear mathematical test that I want to spare you all of, but just know that there are clear rules about how to determine what limitation needs to apply. But in contrast, I will say that historically, the non-quantitative treatment limitations have remained a challenge. And, if you're familiar with, just living it yourself, you'll notice that a lot of these medical management techniques are very hard to understand. I think the requirements are also hard, but a lot of times the limitations are very amorphous. They're not always in the materials that are given to individuals, right? This might be in certain documents that are more so internal to the plan or given directly to providers and about how making, certain claims determinations. And so that has really remained a challenge. And in addition to that, plans and issuers under the law weren't required to actually write out their compliance. So just imagine trying to navigate these very complicated limitations and these complicated requirements, but there isn't an affirmative requirement to document the compliance. And so fast forward to 2021, Congress enacts the Consolidated Appropriations Act, which does now require plans and insurers to document their compliance. And so I always find it very interesting that in a law that was really largely about surprise billing, the earliest effective date was the requirement for plans and issuers to document their compliance with these mental health parity requirements. And so I really take that as a cue of how important this protection was. And so in addition to plans and insurers being required to document their compliance with respect to these medical management techniques, there was also a process that was laid out in the Consolidated Appropriations Act where the departments needed to request at least 20 of these analyses from plans and issuers, but also in any case where there's potential non-compliance. And then there's a very specific statutory process where we undertake a process to determine whether or not the plan is complying. We issue an initial determination. Upon that, they need to come up with a corrective action plan about how are they going to fix their non-compliance. And then to the extent we continue to see issues, we would issue a final non-compliance determination. And then the statute requires that the planner or issuer has to notify individuals of those violations within 7 days. So, we were very excited about this tool that really kind of clearly lays out what the expectations are in terms of compliance and also communication to individuals about what plans and issuers are doing to correct, but also what violations are existing. And so we had issued some FAQs related to those statutory requirements to really just spell out what we were expecting in terms of compliance with respect to these comparative analyses. That's what they're called under the statute. And so you'll notice this is available on the Department of Labor's website. There is very detailed information really trying to get to specificity here. And so I think it's important to highlight that in addition to making sure that this is detailed for the departments to determine compliance, we did issue in the set of FAQs that individuals are entitled to request these analyses as well, so they can understand whether or not their plan is complying with parity with respect to certain treatment limitations that may apply. And just some other takeaways that I do like to highlight when I speak with people when they're either considering medical management techniques under the plan or they're thinking about their parity compliance. From the department's perspective, I really think it's important to keep the participant or the individual's perspective in mind. What I've noticed a lot just being, at the Department of Labor and where I sit, oftentimes we have individuals calling is because they're in the middle of a benefit dispute. They're unsure what their plan will cover. They're unsure of what the limitations and the permutations of that limitation might be. And then what happens is we try to help that individual, but then eventually what will happen is we'll look to see, and this might be something that's actually happening across the plan. And so we'll refer it over for enforcement. But I often feel like if in the first instance, the plans and insurers take care to ensure that there is clear communications to individuals about their benefits, perhaps some of these things could be headed off from the start. And so you really want to think about, clearly communicating what the plan does and does not cover, what's the process for actually receiving benefits. I think that can go a long way. And as if you follow some of the reports that we've issued over the year related to mental health parity, you'll know that a large number of our enforcement actions actually start with that participant complaint. And so I really think it's important to make sure you integrate, your communications on benefits, making sure that the frontline staff who are adjudicating the claims are also understanding of what the requirements are. I did want to talk a little bit about the report that we issued just recently. In addition to the new requirements to issue and then also request the comparative analyses, we have to report to the public and Congress annually on our efforts. And so the last report we issued was in January, and we are working very hard to issue the next report very soon. But we just basically highlight all the comparative analysis we've requested. I will note that in this first report, we noted that initially all of the comparative analysis we requested were insufficient. And so we had to embark on that process to determine whether or not they were in compliance. And you'll be able to expect some follow-up on those cases in the next report. I think the other thing I'd like to highlight that you should keep an eye out for is we are working on additional proposed rulemaking in the space. We did indicate this in our last regulatory agenda that's publicly available. And I hope that will be out soon, but we really want to kind of provide some more protections with respect to what we've issued thus far. Also just taking into account our enforcement experience. It's been some time since we've issued final rules, so we would like to revisit that as well. And then lastly, we are going to update our self-compliance tool. So this is essentially the same tool that our investigators use when they evaluate a plan's compliance. We make it publicly available so that plans and issuers can also evaluate their plan. And so as we work on proposed rulemaking, we would like to update this tool to take into account some of the new requirements under the law. So I think in addition to those issuances, I think you can expect to see the department continuing to engage with stakeholders on an ongoing basis. We typically try to meet and convene stakeholders on a regular basis. Joy will recall we've held stakeholder round tables. We really want to make sure that we are understanding the issues that various stakeholders are facing and making sure that we're trying to respond as much in real time as possible. I think you will also be able to continue to see a focus on enforcement with respect to non-quantitative treatment limitations. As I mentioned before, it's a very complicated area, and I think we really want to raise the bar in terms of compliance. And so I think you will continue to see activity there, especially NQTLs related to network adequacy. I think we all are aware of some of the challenges there, and I think we want to utilize this tool to really help ensure robust networks with respect to plans and issuers. And also too, I think you'll tend to see just a all hands-on approach that we've been taking. I think this is one of the agency's highest priorities, as well as the department. And before I wrap up, this is not really mental health related, but I do think it's relevant. I did also want to highlight, in addition to mental health parity, that the preventive services requirements under the Affordable Care Act also offer some, require plans and issuers to cover without cost sharing certain depression screenings, certain interventions with respect to pregnancy and postpartum persons. And so I know while we are focusing on mental health parity, I think it's important to just look at all the tools that are available to make sure that individuals are getting the coverage that they need. So with that, I will turn it back over to Joy. Thank you.
Amber, thank you so much for sharing the background and for your leadership at the Department of Labor. 2020 Mom, or now the Policy Center, was honored to be a part of the roundtable that you hosted in DC in the fall, and will continue to be a strong partner of the Department of Labor in this work.